Very good morning. Today let's get started on our very small topic but a very important topic, that is your BCG lymphadenitis. So this is very important for your theory exam, for your viva question, and also for your practical purpose, it is clinical purpose also. So how to approach a child with isolated BCG lymphadenitis, that is mainly in an immunocompetent child. So for diagnosis of a BCG lymphadenitis, you should mainly focus on these 4 points. That is, first one, there should be a history of vaccination on the ipsilateral side of the lesion. This is ipsilateral side of lesion. Second point, there should be an absence of other signs of infection. There should be absence of other signs of infection. Third point, absence of fever should be there. Fourth point, you can identify a isolated supraclavicular or a cervical, this is supraclavicular, or a cervical node enlargement, which can be seen through your USG or a CT scan. These are the 4 points that you have to mainly focus before doing a diagnosis of a patient with BCG lymphadenitis. So till what age group this BCG lymphadenitis can occur? This can occur till the age group of 4 years, right? Next, how to approach a child with BCG lymphadenitis? Here you have 2 groups. It can be either a suppurative one or it can be a non-suppurative lesion, right? Suppurative meaning there will be a pus collection in there, so the child will have a progressive enlargement. So in a suppurative lesion, child will be having a progressive enlargement of that particular lesion. Next, there will be softening and fluctuation of that swelling. If this is left untreated, if you left untreated, it will go to form, it will go permanently, or it will progress to rupture and form a caseous discharge, or a sinus formation will be present. So if left untreated, it can progress to rupture and there will be a persistent caseous discharge and a sinus formation can occur if your suppurative BCG lymphadenitis is left untreated. Well, coming on to your non-suppurative lesion, how it will be present. So the non-suppurative lesion is always a benign course. It does, its size does not exceed, the size do not exceed 15 millimeter. So this one do not exceed 15 millimeter. It will be firm in consistency and it will resolve spontaneously without any sequelae. That is the main point in a suppurative lesion. It will resolve spontaneously without any sequelae. While in suppurative lesion there will be a sinus formation, here there won't be any sequelae left. Okay, so how to treat a child with a suppurative lesion? First, you can do a needle aspiration. You have to do a needle aspiration, drain the pus. Okay, supposing if the needle aspiration has been failed, that is, this child is having a recurrence of a lesion, then you can repeat a needle aspiration. If this is also being failed, then you have to do a surgical excision, right? This is the management protocol for a child with a suppurative lesion. Next, if the child is having a non-suppurative lesion, it is always wait and watch. If the lesion regresses and then recurs, if it regresses and then recurs, then you need an expert opinion, and you can start a anti-tubercular drug, that is HRE, for about 3 to 6 months. So this non-suppurative lesion is always wait and watch only. Only if the lesion regress and again if it recurs, then you go to start on with your anti-tubercular drug, that is HRE, for 3 to 6 months. Actually, there is no role for anti-tubercular drugs and antibiotics in a child with the BCG lymphadenitis. So there is no role for antibiotic and anti-TB drugs initially. Okay, this is your take home point. Thank you. This is a very small topic. I hope everybody are useful with this BCG lymphadenitis. It is a very important topic even for your MBBS final year exam, okay, and also for your Viva session. Thank you so much for your patience listening.